And I want to welcome those of you who haven't been to our seminar before, or some of you I think have been years and years ago presenting yourself, so it's nice to have you back. And a lot of our former students, so welcome to our alums. We miss you. Come back and visit us when it's safe. And then a lot of the students who've been part of this project as well, so I'm glad to see that group here. I'm going to go ahead, I think, and let me let one more person in. You got it. Good. I'm going to go ahead and get us started, at least on my part, so that we give Dr. Peahl plenty of time to talk. So first and foremost, again, I just want to welcome those of you, well, welcome all of you, but especially welcome those who haven't been to the seminar series before, and make sure that you know where to find us for future talks. And to share this with colleagues that you think might be interested, or with students that you think might enjoy being part of research like this in the future. I want to remind everybody that we will not have a seminar next Monday. That's the annual Informed meeting, which is our big professional society meeting. And so even though it's virtual, we're still going to have people presenting talks and giving talks. And so that also buys you a little bit of a break, I know, for the students. Midterms and stay-at-home orders and bad weather and everything else have made this a rather daunting time. So consider next week your healthcare seminar assignment is to take care of your mental health, and use this time to go take a walk or look at pictures of cats or something that is soothing to you. Please vote if you're eligible. If you haven't yet, please vote. You will hear it from others other than me, but please vote. Healthcare is obviously an important issue in this election, as there are many other things that are important to our well-being. So I think with that, we've got a very good turnout. I want to turn it over to Dr. Peahl. She's the reason we've had this change in schedule time is to accommodate her clinic work. So I'm especially grateful that she not only is taking the time to prepare and present to us, but that she's doing it on top of a very long day, but obviously is able to talk quite relevantly about work that is going on that's current as of the last few hours or moments. And I'm going to allow Alex to introduce herself and her work. Renata will be manning the chat. So if you have questions along the way, just go ahead and pop them into the chat, and Renata will, at the appropriate time, interrupt Dr. Peahl to get some responses for you. And then we'll hopefully have some time at the end for Q&A. But with that, I'm going to go ahead and mute. And again, thank Alex for joining us, and welcome everyone, and we'll get started.
Perfect. Thank you so much, Amy. And it is just such a pleasure to be here with all of you today. Today, I'm going to talk about right-sizing prenatal care and how we're going to be able in the upcoming years to tailor prenatal services to meet patients' needs. Before I hop into that, I do want to echo Amy's sentiment about voting. We are on the eve of election night, and I just want to remind everyone to get out there and vote. So before we start, I do just want to share a little bit about my funding and my framing. Some of the work that I present today did receive funding from the Blue Cross Blue Shield Foundation, which is totally separate from the payer, and also some money from IHPI. But perhaps most importantly, I am a clinician, not an engineer. So please feel free to stop me at any time if I'm using jargon that doesn't make sense. I'm going to rely on Renata and the CHEPS prenatal team, who's been calling me out for about 2 years now, to let me know when I'm using language that might not make sense. The other thing I want to share is that this work represents a cumulative thinking of many people, particularly the many engineers in my life. So I've been really fortunate to be surrounded by engineers my whole life, which I think you'll see reflected in my work and my thinking. My dad, my husband, my father-in-law, and since coming to Michigan, the amazing CHEPS team have all helped me to really shape how I think about healthcare through perhaps a slightly different lens. These relationships have really taught me how interprofessional thinking can advance our ideas, get us outside of our silos, and work to improve patient care overall. So today, I know we have a few pre-health students in the audience, and I just want to start by sharing how I came to study prenatal care to give you a sense of one of the many possible career trajectories that we have in medicine. Next, we'll go over prenatal care prior to the COVID-19 pandemic, and then how we rapidly responded, incorporating telemedicine and more. And then finally, I'll talk about how we're right-sizing care for the future. And throughout this, I'll share how our work with CHEPS and the prenatal team here has continued to shape our thinking and our efforts. So I grew up in the heart of South Carolina, in Columbia, but my journey to studying prenatal care really started in my time as an undergrad in St. Louis, so at the same stage that many of you are at. There, I had the opportunity to serve as an intern at the Spot, which was a reproductive health clinic for youth age 13 to 24. If you walked into the space, you would have had no idea that this place was a clinic. It had lime green walls, there were video games and snacks, and it was located in this really convenient neighborhood that was close to the metro system and the buses. Youth were welcome to just come and hang out there. But if they had a need for contraception, sexually transmitted infection testing, mental health support, everything was there available right behind the doors. So as I moved from college to med school in Chicago and Rhode Island, my family thought I was crazy because it just kept getting colder and colder where I was living, and I had to leave those southern winters behind. But rather than comparing the weather, I actually found myself consistently comparing the medical care I saw in both medical school and residency to how care had been delivered at the Spot. Rather than delivering care in the context of patients' communities, prenatal care in particular seemed designed around the health system itself. I watched as many of my pregnant patients had to make difficult decisions between attending their prenatal visits and other life obligations, attending work, taking care of their kids, saving money to put food on the table. And I started to wonder if we might be able to provide care in a better, more patient centered way. So, following residency, I decided to pursue a 2-year fellowship in health and health policy through the National Clinician Scholars Program. And that's how I made it here to Ann Arbor. Through that process, I spent 2 years understanding the evidence, or really the lack thereof, behind prenatal care delivery and learning about the policy levers that might be available to improve it. So that's a little bit about my story. Before we go any further, I'd actually like to hear a little bit about your experience. So if you're willing, think about the last healthcare experience you had, whether it was your flu shot, an emergency room visit, a time in urgent care. And how was that experience designed to meet your needs? Or was it? So I'll ask that you take a few moments and put your reflections in the chat box. And this can really be about anything, any time that you needed healthcare, even down to getting your eyes checked. Amazing. So Amy's had some really positive experiences with nurses who've been able, it sounds like, to maybe redesign some of these systems to meet her needs. Oh, this is nice. A COVID-19 test that met the needs for social distancing, et cetera. I got to do mine through the drive-through, which was kind of nice. And they even had a tissue waiting for me for when your eyes are a little teary. Um, wow. And then rescheduling to get an appointment the same day. Um, Oh, Hannah, it's great to see you on here. Hannah's work is actually going to be presented today, some of the work that she did during the COVID-19 pandemic. But she had an ACL repair and was struck by how confusing it was to navigate the details prior to surgery. And then lots of reassurance, great design from the flu shot, and then asking for questions. So I am thrilled to hear that so many of you have had really efficient and effective healthcare. And I have to say, this is a little bit different from the reaction I've gotten as I've presented this topic nationally. And I think that really reflects the integration of some of the amazing services we have here at U of M. When I present nationally, these are some of the things that people tell me about their healthcare, that they had to take a bunch of time off of work or school in order to be able to receive services, that once they finally got to that appointment that they'd waited for, that it felt rushed, or if they had to cancel for other reasons, that they felt judged, that they've had to see a different provider than who they chose, or that their questions weren't answered. And the long wait times are things that we hear about really often in a system that maybe isn't as well designed as the one at U of M. And I see in the chat we have other examples of both positive and negative healthcare experiences. Thank you guys so much for contributing. We'll have a couple other points where we'll get you to weigh in. So for most patients, I would say that the healthcare experience was not designed to meet their own needs. In fact, often our healthcare experiences are designed around what makes most sense for the health system. And for our pregnant patients, this can mean almost a year of their lives are filled with care that's challenging to access, disruptive to their daily lives, and can often feel them leaving unsupported. And so today we're going to talk about how we can rethink prenatal care so that other patients can have the same positive experiences that you guys have had, and how systems engineering can be helpful for understanding these questions and redesigning care experiences. So first, I just want to get us all onto the same clinical background. So after today, you guys will all be OBGYNs ready to deliver prenatal care. So what exactly is prenatal care? Going back to the basics, according to the most recent American College of OBGYN, or the leading national OBGYN society's guidelines, prenatal care is a preventive care service to improve the health of moms and babies through three key components: medical screening and treatment, that's checking and managing any disease of pregnancy or a comorbidity before pregnancy; anticipatory guidance or education about pregnancy, childbirth, and the postpartum period; and finally, psychosocial support, which is really helping patients access the non-medical resources that patients need to successfully navigate pregnancy. Prenatal care is actually one of the most common preventive services in the United States. And each year, there are almost 4 million pregnant patients who give birth, of whom almost 100% will receive prenatal care during their pregnancy. Current prenatal care guidelines, at least prior to the COVID-19 pandemic, recommended 12 to 14 in-person visits over the course of pregnancy. Here you can see this blue icon. At University of Michigan, this represents a phone intake that the nurse conducts with the patient. And then each of these little yellow icons represents an in-person visit, with the orange icon representing an ultrasound, which we commonly refer to as the anatomy ultrasound, or where patients historically found out about gender. You can see that there are a ton of services that are delivered over these 12 to 14 visits, including physical exams, laboratory tests, and other pregnancy services. Interestingly, this schedule is recommended regardless of medical or social risk for our patients. Whether you're high risk or low risk, the recommendation for 12 to 14 visits remains the same. And if this looks like a lot of care, you are right. This care is time consuming for pregnant patients and adds up to over 40 hours over the course of a low risk pregnancy. That's the equivalent of a full work week. And that's if everything goes perfectly. For many patients, this leads prenatal care to be low value, no matter what definition you use. If you look at outcomes, we see in the United States that we have the highest maternal morbidity and mortality rate of peer high-income countries. With regards to access, a quarter of patients don't establish care until the second trimester, though we recommend they present early. And clinics face capacity issues for new patients, in part because of these excess appointments. And finally, if we look through an equity lens, minority and low-income patients have lower access to prenatal care and also have worse outcomes. Perhaps this low-value care isn't surprising, given that prenatal care guidelines have remained unchanged since 1930. So here on top, you can see the original prenatal care pamphlet that was published by the Children's Bureau in 1930, when prenatal care guidelines were first codified. And their suggestion for visit frequency is the same as the guidelines that were published by Acog in 2017. There's a lot that's changed since 1930, including the founding of the American College of OBGYN, the discovery of ROGAM, which helps us to prevent a complication when mom and baby's blood mixes. We've had ultrasound, home pregnancy tests, revolutions in genetic testing. And despite these drastic changes in the profession and technology, prenatal care delivery recommendations have remained completely unchanged. So recognizing that prenatal care was really due for an update, we began investigating prenatal care redesign over 2 years ago. We were doing this here at the University of Michigan, and for those who aren't familiar, we deliver almost 5,000 patients a year. They're cared for by over 150 maternity care providers across a variety of specialties, and they're seen in 12 outpatient clinics. And we sought guidance from two key areas: first, evidence, and second, from our patients. We divided the evidence into two key components. First, prenatal care services, or the what of prenatal care, the care that's provided, including screenings and management. And the second piece was the how, or prenatal care delivery, the way patients receive that care, including the number of visits and the modality, or things like telemedicine. What we saw was that many prenatal care services are evidence-based, things like screening for gestational diabetes or checking for if the baby's head is down before delivery. There's good evidence to suggest that these are important things for us to do. But the evidence for prenatal care delivery was less robust. In 2015, there was a Cochrane review, which is a big synthesis of the evidence of over 5,000 patients in high-income countries, so countries just like the United States. And that review found that reducing prenatal visits from 14 to 9 did not change outcomes for mom or outcomes for baby. And in fact, that 12 to 14 visit schedule actually may be harmful for low-risk women. In a study of over 12,000 low-risk patients delivering at a single institution, the authors found that over 10 prenatal visits was associated with increased intervention without improvement in outcomes. This suggests that more may not actually be better, and in fact, it might lead to unnecessary intervention. We also looked to our peer countries to understand what guidelines were being recommended in places with better healthcare outcomes for pregnancy than the United States. And you can see that the United States recommends more prenatal visits in almost all other countries except for Japan. Japan has a very different healthcare model. And every country on this list has better pregnancy outcomes than us. In our initial review, before the telemedicine boom, telemedicine had emerged as a promising option for routine prenatal care delivery. Early studies had shown equivalent maternal and fetal outcomes, high patient satisfaction, and a positive care experience, and finally, even cost savings for the health system. So to summarize the evidence, we have strong supporting evidence for prenatal care services, or the what of prenatal care. But evidence actually supports quite different models than are currently used in the United States. So next, we really wanted to understand the patient perspective and get a feel for patients' experiences with prenatal and postpartum care. We started right here at U of M. We surveyed 300 patients who had just delivered and were admitted for their routine post-delivery hospitalization. And we used a tablet-based platform to survey them. What we learned was that over 2/3 of patients preferred fewer prenatal visits than the current recommendation for 12 to 14. And the majority of patients preferred telemedicine contacts between their visits. In other words, they wanted a more flexible model of care. Finally, the majority were comfortable using home devices to check their blood pressure, their weight, and to check the baby's heart rate at home, which we do with a device called a fetal Doppler. We also wanted to make sure that diverse patients' voices were included in our sample. So we conducted a human-centered design project with patients and healthcare workers in outpatient clinics in Detroit. And we focused specifically on low-income Black pregnant patients who have had the worst maternity outcomes in the United States. For those who aren't familiar with human-centered design, this may be a term that you've heard in industry, but it's being increasingly used in healthcare. And this is a method to design creative solutions from viewing problems from the user's perspective. We used 2 tools from this methodology. The first was journey mapping, where we had pregnant patients and their providers map out the entire prenatal care experience from the moment they found out they were pregnant until they delivered. The second tool we used, I like to call it the magic wand. We had participants imagine a world with no limitations, no restrictions, and describe what they hoped the prenatal care experience would be like for pregnant patients of the future. And I just wanted to share a little data from our preliminary analysis. There were a few key themes that emerged as participants described current prenatal care delivery. Many referred to the burden and lack of fulfillment in current prenatal care. As one patient reflected on her prenatal visits, she said, "I know she, the doctor, is just going to check the heartbeat, and it's going to be like 10 minutes. No, I'm not going to waste my gas. Back then, I was surviving. I don't want to waste my gas just to go out there for 10 minutes." Others referred to the lack of customization in prenatal care. A healthcare worker noted that this is exactly how we do it. This is our cookie cutter. We're going to make this mode, and you cannot go outside of this box. And finally, others reflected on the medicalization of pregnancy and the treatment of all patients as if they were high risk. As one patient reflected, clinics and hospitals treat everything as high risk. Everything isn't urgent. If it's not high risk, it shouldn't be treated as high risk. So I would say these experiences are quite different from what I saw in the chat box from many of you at the start of this presentation. This care really wasn't meeting patients' needs. It's incredible what happens though when you give patients the magic wand and let them design prenatal care for the future. There were several themes that emerged around the delivery of ideal prenatal care. These included the need to tailor care to patients' needs through customizable options, moving away from a one-size-fits-all model to a model that's designed to meet what patients need. Second, patients reflected on the need to integrate medical and social services. For example, participants noted it was helpful to have social work and medical visits in not only the same location, but that ideally the care providers would coordinate their plans together. Improved accessibility of care was a huge theme through convenient locations and flexible access to services, wider hours, and the use of telemedicine to make care easier for patients to get. And finally, all patients and providers reflected on the need to create safe spaces for questions and education without judgment. I love this quote from one of our healthcare workers. I think it sums up these sentiments quite nicely. Culturally, we plan for weddings in all types of options for what that looks like, whether it's destination or courthouse or in your living room. Who do you have with you? I would love to be able to see what we can have when we can have all of the options for what a pregnancy could look like. So following this initial work, we summarized the prenatal care goals, our literature review, and patient feedback. And from that, we were able to derive two key principles to inform prenatal care redesign. The first was to design care delivery around essential services, and the second was to create flexible services for anticipatory guidance and psychosocial support. But this required thinking about prenatal care quite differently from how we had before. And so we created a new conceptual model, which I'll walk you through now. So previously, our prenatal care model had been based on medical needs. And high medical needs can really derive from three key sources. That is pregnancy history, where a mom may have pregnancy risk factors, personal medical history, things like high blood pressure or diabetes, or as the pregnancy goes on, those medical needs can actually be from the fetus, things like anomalies, congenital disorders that might require additional management. And these medical services are typically matched to these medical needs are typically matched to corresponding medical services. I do want to highlight that even this distinction is really not clear in maternity care. Low risk varies by region, by provider, but suffice it to say, regardless of the variation, we use medical risk to determine prenatal care delivery, like provider type, screening, and treatment recommendations. What our current system has poorly characterized as support needs, which can include anticipatory guidance, that education component, and psychosocial support. You can imagine two very different patients, a multiparous woman or a woman who's had multiple babies before, with a strong network may have low support needs, but a first-time mom or someone with housing or food insecurity may need more assistance. Our current system just layers on support needs on top of medical care, adding education, counseling, or assistance for material needs. But this is on top of an already burdensome system. This creates more burden on top of the 40 hours already required for routine prenatal care. And this could disproportionately affect low-income working patients or patients with childcare needs who already had difficulty meeting established recommendations. So when we combine our medical and social needs, there are four key patient phenotypes that emerge, those with high and low medical and support needs. And ideally, we would match these with 4 levels of prenatal care service intensity, again, based on medical and social needs. But unfortunately, in our current model, we just put everybody in the high medical, low social care intensity box with 12 to 14 visits. And additional visits are added on for higher medical and social needs with no chance for de-escalation. In an ideal model, however, we would match all of these services to needs and right-size prenatal care. So this is great in theory, but we wondered, could these principles actually be applied in practice? Would it be feasible to put right-sized prenatal care into action in the real world? This was the question that I first connected with CHEPS on almost a year and a half ago. We were able to translate this clinical question, can we right-size prenatal care for our patients, into a more systems engineering approach. Could we understand how complex patient and organizational factors influence care utilization? We met a couple barriers as we started on this project. The first barrier was defining these phenotypes. There were no established medical or support scores to help us think about prenatal care delivery. The second barrier was assessing utilization. Most utilization comes from large insurance databases, but prenatal care is paid in a single payment for all of the visits, and that masks the individual visit signal when you're looking at these big data sources. Instead, we needed to look in an electronic health record. Finally, we wondered if these phenotypes could actually reflect different outcomes, or if this was just a construct that we had created. And so we sought out Data Direct, which is a footprint of the EHR that's available through Precision Medicine for our exploratory analyses. There were a couple of key steps here in our process. We first had to develop the medical and support scores based on data that we had available in the EHR. And these scores weren't perfect. We do not routinely collect social determinants of health as part of routine prenatal care, for example, leaving some gaps in our ability to define patients. Next, we needed to look at prenatal visits, but also non-visit utilization, things like phone calls or portal messages that could also reflect patient needs. And then we wanted to look at the differences by patient phenotype. So to create our score, we defined phenotypes using available EHR data. We defined medical components as those that affect the utilization of routine maternity services. Those would be things like comorbidities, hypertension, diabetes, as well as pregnancy conditions that could affect the intensity of pregnancy care. We defined support needs as those that affected the utilization of psychosocial support and educational services. Things like how many times a patient had been pregnant before, her income, her social determinants of health. And there were some components that belonged in both scores: mental health, substance use, things that may require greater medical intensity, but also greater support intensity. And then we looked at utilization broadly. Prior work has only looked at the number of prenatal visits that patients attend, but we thought that phone calls and portal messages might be a marker of unmet education and support needs. We also looked at no-shows and canceled appointments to better understand issues of access. So when we looked at the almost 5,000 patients who were cared for in our hospital system, you can see that their risks differed quite a bit over the course of different patients, both medically and in their support scores. And we could divide these patients into 4 phenotypes. We conservatively set our cut points for high risk at just 1 point, and you can see that the patients fell into those 4 boxes. I do want you to take a moment to just familiarize yourself or reacquaint yourself with the colors here, because these will be important as we move through the next slide. So pale green represents low medical, low social needs. Dark green, high medical, high social. Yellow is only social needs, and blue only medical needs. So here you can see the 4 patient phenotypes with low medical, low support, high medical needs across the x-axis, and the mean number of visits on the y. Now, these visits don't quite vary as you might expect. You can see that the mean number of visits was the same for patients with the same social risk. So patients with low social risk had a mean of 10.5. Patients with the same social high support needs had a mean around 8 or almost to 9. So in other words, average number of visits tracked more closely with social, not medical risk factors, which seems a little strange. Again, you see the 4 patient categories, and now the bars are split into 3 parts. You can see the lowest segment, which we saw before. This is visit number. The middle is phone calls, and the top is portal message. Overall, patients with higher medical needs had a higher number of contacts with the health system than those with lower needs. But again, we see that those without support needs were having more contacts with the health system than those with high support needs. Now, this could mean a lot of things. It could reflect the worried well contacting our system more and desiring more contact with us, or it could suggest that socially at-risk patients have increased barriers to care, like time and concerns about access. And these are things that we'll be exploring in the future through some of our qualitative work. Interestingly, when we look at health outcomes by phenotype, we see a stepwise increase in rates of preterm birth with increasing risk factors, suggesting, again, a need for a deeper dive into this data. And interestingly, you can see that there's a greater proportion of Black patients who we know are at higher risk of disparities in quadrants B and D, the higher psychosocial risk groups. This demonstrates how patients of racial and ethnic minorities may face higher adverse social determinants, which may contribute to the worst pregnancy outcomes, even at the same level of medical risk. So, can we right-size care? Our early work suggests yes, we can create patient phenotypes. We can understand patient-driven utilization and outcomes across those different groups. And perhaps we can use that to plan care to meet patients' unique needs. So this is where we were in February of 2020 with the beginning of the COVID-19 pandemic. And with the COVID-19 pandemic, we had to assemble our team to revise and implement a new prenatal care model. This really occurred with the need to limit outpatient visits to only urgent ones. Our initial guidelines had to prioritize public health needs for social distancing, but we did recognize that patient preference would have to play a more integral role later as we moved out of the pandemic and into new care models. So we wanted to ensure all of the recommended services were included in our new prenatal care model. And to do that, we went back to our principles, to design care delivery around essential services and then create flexible services for other patient needs. And this is what it looked like. We identified the needed in-person services like exams, labs, and vaccinations that couldn't be completed from a patient's home. And that translated into 4 total visits and then that anatomy ultrasound that I had mentioned before. We then identified the critical prenatal services that could be completed remotely, things like counseling, mental health screening, assessing for patient symptoms. And those translated again into 4 visits that we interspersed in between the scheduled in-person care. And that resulted in our COVID-19 schedule of 4 in-person visits, the anatomy scan, and 4 virtual visits, which Dr. Johnson, who I see on this call, coined the 414. So depicted differently, that care model looks like this. You can see all of the same care services are available. They're just a little more condensed than before. And while the baseline schedule was created for low-risk patients, we also included recommendations for patients with more pregnancy or medical risk factors, those on the right-hand side of the conceptual model. You may have noticed that in the prior prenatal visit schedules, I showed checking blood pressure as a usual part of routine care. We were prioritizing patient safety in the beginning of the pandemic, and remote monitoring of blood pressure was not required for transitioning care from in-person to telemedicine visits, given the need to prioritize decreased viral exposure. But checking blood pressure can be done easily at home by patients, and we wanted to make sure that we could get those devices into patients' hands. Unfortunately, there was initially a national shortage of blood pressure cuffs, but eventually we were able to secure a donation once those resources became available. And that was particularly important to us because of the challenge that arose with equity, where our patients who could afford cuffs were able to go out and buy one on Amazon, but patients who couldn't afford were left behind. We also recognized that the one-size-fits-all plan that we rolled out during COVID-19 wouldn't meet all of patients' needs. And so we did try to create opportunities for tailoring where possible. This included anticipatory guidance with online education and psychosocial supports through our large group and small group meetings of Stay Home, Stay Connected. We included online resources, including new patient-facing content on our website, and provided patients access to a prenatal app. And these are all publicly available still on the U of M website. And then we also created an online program that was modeled on group prenatal care to provide social connection and peer mentoring. The program consisted of both monthly small group sessions and then continuous connection through a Facebook page, and finally large group mental health skills sessions led by behavioral health experts. To give you a little more detail, the online small groups included 8 to 12 participants, 1 to 2 student facilitators from a variety of disciplines, and a pregnancy provider. So those groups would meet in the beginning of the month, and then there were weekly sessions to help patients feel connected to information and also to mental health resources throughout the rest of the month. The CHEPS team played an important role in many areas of the OBGYN team's consideration of care delivery. The team helped first during the pandemic to recalculate our staffing needs based on changes in the prenatal schedule and clinic closures, helping us to make better plans for covering services during the pandemic while also keeping our providers safe. And they also helped us with reconsidering systems capacity for specific tests in high-risk pregnancy, something called a non-stress test or a 20-minute monitoring of the baby's heartbeat. As I'm sure you've heard from other speakers who've mentioned the COVID-19 pandemic and from some of the work of folks on this call, everything moved really quickly. Our guidelines were developed on the 18th, approved the 20th, and launched the 23rd, the same day that we had our state stay-home orders. We had students call all of our patients starting March 24th, and Hannah was one of those students who participated in that to help give patients reassurance. We received our blood pressure cuffs at the end of March and started Stay Home, Stay Connected in the beginning of April. And our guidelines here at U of M were endorsed by national organizations, the ones you see here, as not only approved for care during the pandemic, but also as a model to consider moving forward. Though our new care model was based on evidence and strong principles, we wanted to ensure care delivery was meeting patients' and providers' needs. And so we assessed two key components of the new model. We assessed adoption using electronic health record data, including average weekly visit volume and proportion of virtual visits. And next, we assessed patient and provider experience using surveys. Surveys were based on quantitative questions from the telemedicine usability questionnaire, a validated survey instrument. And then we also used open-ended responses to get deep, rich feedback to inform the next steps in our model. And when we thought about experience, we included three key domains: access, or the ability to receive recommended services; quality and safety, the ability to effectively deliver those services; and finally, satisfaction, how much do people want to use what we have made? Here you can see the changes in overall prenatal visit volume and the uptick in telemedicine before and after implementation of the new protocol. So while caring for the same number of patients with a stable no-show rate, our volume fell from over 1,000 prenatal visits per week to just over 700, while the proportion of virtual visits increased from 10% to 40%. And you can see those virtual visits in the orange and the gray. Here you can see some demographics from our survey. So we just pushed this survey to patients through the EHR portal in a one-time message, and then our providers received this through division listservs. And the demographics of our populations match the usual populations of both patients and providers here at U of M. Our survey showed an overall positive care experience. Patients and providers thought that the virtual visits were really easy and improved access to care. Most thought that virtual visits were safe, but the majority of patients and providers felt that blood pressure cuffs were crucial for making telemedicine visits feel comfortable and safe. And finally, satisfaction scores were really high for the new model. But when we looked at the free responses, we learned a little bit more about patients' experiences with the new model. While the COVID-19 model reduced barriers to care, there were concerns that this model could worsen existing inequities through the digital divide. For quality and safety, patients and providers noted the models were a good match for low-risk patients' care needs, and they liked that they could maintain safety in the pandemic. But everyone worried that something could be missed without home devices. And finally, for satisfaction, patients and providers noted improved counseling for virtual visits. And I can attest to this from my own virtual care. It's really nice to sit face-to-face with a patient with no other distractions. Patients also noted improved empowerment through putting the tools for prenatal care in their own hands. But still, lack of continuity and the need for more visit preparation detracted from overall satisfaction scores. And again, I just want to share with you some of our patients' and providers' voices. Here's a quote about access. This patient liked the time savings it brings, especially for appointments that were just a check-in, where I didn't require an ultrasound or anything additional. Previously, I would need to block 1 to 2 hours for a 10 to 15-minute in-person visit. For quality and safety, one patient reflected that it gives enough time in person while allowing for easy check-ins and is a better use of my time for between visits that are mostly dialogue. But another patient reflected concern. I dealt with high blood pressure and preeclampsia in my last pregnancy. With the new model, I felt like this could be missed. And finally, for satisfaction, one of the midwives reflected it puts more of the prenatal care back into patients' hands, teaching them to self-check blood pressure and monitor fetal kit counts instead of having maternal self-awareness supplanted by devices. But another patient reflected, I also did not feel prepared with what to expect from a video visit compared to an in-person visit, reflecting the need for better preparation. So from this initial rollout, what have we learned? First and foremost, what we knew before, one size doesn't fit all. Prenatal care plans need to be based in a consistent foundation, but they also have to flex to meet patients' needs. Home devices are a must for patients and providers in virtual models, and we've been working with payers across the state as well as national organizations to ensure these devices can be put in patients' hands. Optimizing virtual care requires better patient preparation. Patients need to know what to expect. Patients want to see the same provider in person and virtually. And finally, providers need time and space in their schedules to see these patients. And lastly, we saw that the wraparound online education and groups provide patients with important support. And as always, we're ensuring that equity continues to be a priority for us. We've been reviewing all of our plans and materials with patient advisory boards, both locally and through a PCORI group nationally. We're making sure that patients who don't have access to broadband and therefore can't do video visits are able to call in and do phone visits instead. And finally, we're going to keep monitoring our patient experience to make sure that we aren't exacerbating access issues, decreasing the patient experience, or making disparities worse. So as we've moved out of acute COVID, we've been able to pause and reflect on the past few months and think about the next best steps for the future. And we're using our experiences during the pandemic and patient feedback to build an even better model of care. What I'll share with you today is what we're doing locally here at Michigan Medicine, but we are also leading the national guideline redesign for Acog, the American College of OBGYN, to rethink care for every pregnant patient. And we anticipate that those guidelines will be released in January. And all of the work that we've done here at Michigan Medicine will inform that guideline process. We're calling our new plan MyPath, the Michigan Plan for Appropriate Tailored Healthcare in Pregnancy. And in this plan, patients will work with their providers to select their own pathway that remains flexible. So if their medical needs or personal preferences change, the care plan can be adjusted. In this model, patients work with their providers to pick from 3 key streams, all of which work synergistically together. Patients can pick their visit type from in-person visits or a hybrid model with virtual visits and home devices. And finally, group care or centering. But with that, they'll pick their support, including their education, which they can use classes, apps, books, and if they need additional support from things like online support groups or social work, these things will be available too. So this plan is really easy for me to sign on to as a clinician. It delivers the right care for the right patient in the right place at the right time. But there are a lot of important logistic concerns to entertain when thinking about totally turning prenatal care upside down. And so for all of the systems engineers on the call and for everybody who's participating today, I'd like you to think about what might be important if you were a department chair or head of outpatient operations at Michigan Medicine or at clinics across the country. What would you want to know before you agreed to this plan? And so I'll ask that you put some things in the chat, some of the things that you might consider if you were trying to design or implement this care model. I know this is a little bit of a different hat than most of us wear, but hopefully we can think a little outside the box. What new headcount will we need and what new skills? Oh, this is great. Will the virtual visits include basic training about the safety of health devices? And that even those approved by the FDA need frequent calibration. That's a huge issue that we faced, and it's actually baked into our new model to make sure that those devices are calibrated. Will it be covered by Medicaid users? Absolutely. How do we schedule our providers? That's a huge one. Will it require new tools and technology? And what is the cost? Absolutely. That's a huge one. Do we have a way to determine patient scores if they're new patients to our system? So how do we figure out which path is right for them if we don't have any information on them before? These are all great. Can we change care models for patients during the prenatal term? So can patients move from model to model? And have there been any other types of customization specific to prenatal care attempted before? And what can I expect my outcomes to be? Perfect. That is one of the most common questions I get. Not everybody's convinced from the Cochrane review from 2015. And how in the world am I going to schedule everyone? Thank you guys. These are amazing considerations. And as I think about this, I really divide those questions that I might be asked into two boxes. The first is the health services research box, which I really like to be in. Things like quality and safety, patient satisfaction. Those are things I know how to study and measure. But on the systems engineering side, that's where you guys come in to help us understand access, capacity, clinic flow, staffing, things that I'm not as trained in to measure or to manage. And so again, when medicine meets systems engineering, we're able to translate our clinical question, how do we deliver right-sized prenatal care for our patients, into more of a systems engineering question. How can we understand the impact of changing care utilization and pathways on utilization and access? And this is what the CHEPS prenatal care team is building now, a way for us to understand that complexity. So we're building a simulation tool to understand how complex patient factors can impact our utilization outcomes. And this tool incorporates many of the factors that we've reviewed today: patient medical and social risk scores, patients' care preferences for in-person or virtual care, and the timing of presentation, or when patients enter our system for their first prenatal appointment. And in turn, we can measure how long it takes to schedule them for care, how many patients or clinics are able to see, and if patients are able to receive guideline concordant care. And with that, we can understand what our staffing needs are across the system. We'll also be able to assess the impact of different care paths, that is, those with more or less in-person or virtual schedules, and eventually, potentially even incorporating support services into these models. As new national guidelines are developed, clinics across the country will have to redesign their clinic structures and staffing and consider these new visit schedules. But not every institution is as lucky as U of M to have CHEPS available. And so we're therefore working towards a public-facing tool that would allow clinics to plan for changes in utilization with new prenatal care pathways, regardless of their resources, ensuring that no one falls through the cracks. All right, we've reviewed a lot today. Let's briefly go over the key points. So today you've got your MDs in prenatal care at least, and we talked about what the 3 goals of prenatal care are: medical screening and treatment, anticipatory guidance, and psychosocial support. We discussed how current care delivery requires over 40 hours for all pregnancies, and in spite of evidence to the contrary and evidence that this is low value care, we've persisted with this schedule for over 100 years. Evidence supports that recommended care can be delivered safely with fewer visits and through telemedicine. And from our survey work and human-centered design work with patients, we've learned about what patients want for care for the future. Through all of this, by combining evidence and patient perspective, we've identified 2 principles for prenatal care delivery in the future. And these principles can help to guide a new, right-sized model of prenatal care that delivers services based on patients' needs. These principles help guide care during the COVID-19 pandemic. And with that, we saw significant changes in visit frequency and modality, with an overall positive experience for patients and providers across the 3 experience domains. But modifications are needed. We have to be aware about the potential for worsening inequities. We have to make sure patients have devices in their hands for virtual care. And we need to make sure that there's continuity for patients and providers and that all feel prepared for virtual visits. These lessons have informed new approaches to prenatal care locally and across the country, with patient preference playing a larger role in the next steps for our MyPath prenatal care plan. And throughout this work, before and during the COVID-19 pandemic, I've seen how important the principles of systems engineering are for bringing our ideal clinical practice into reality. Through helping us understand current care delivery and incorporating the complexity of new models, and making sure that no clinic or patient is left behind. I think this Amy Poehler quote sums it up pretty well. Find a group of people who challenge you and inspire you. Spend a lot of time with them, and it will change your life. I am so grateful for my collaboration with CHEPS and the prenatal care team. Y'all have helped to make right-sized care a reality for our pregnant patients, and I look forward to our continued collaboration. Thank you so much, everyone, and I'm thrilled to answer any questions now or in the future.
Thank you so much, Alex. That was wonderful. I think one of the things I particularly appreciate about it is, as someone who is not on the clinical side, having that perspective on how all of the pieces fit together. And certainly thinking back on my own pregnancies and the 2 hours to spend 10 minutes with someone, I think many people will appreciate that. So let me go ahead and open it up for questions. We've got about 5 minutes. And I know that it's a sort of a later time, so if people need to duck off, that's understandable. But otherwise, if you can be putting things in the chat, and Renata can monitor that for us.
Yeah, I've gotten a couple that were sent directly to me. So I'll start with Stuart's question, and he was wondering if there was some variation in willingness to use telemedicine between the different phenotypes.
That's a great question. And we actually put in a big grant to do just that kind of work. Right now, we don't have that kind of granular information. We do know that some patients who face higher social risk factors may have problems with accessing telemedicine. So they may not have access to broadband, or they may not have the smart devices that are required for those video visits. That's why our team has really prioritized having phone and video visits covered at parity. And that has sort of two components. One is a payer perspective, which for us matters a little bit less because all of our visits are paid in a bundle. So as long as the payers say, we don't care how you do prenatal care, then we're okay. But also it's making sure that providers feel comfortable with that model. Our schedulers know that they can schedule a phone visit. And so in order to protect some of those patients who have those adverse social determinants of health, we've made sure that we provide that kind of service. But certainly that's going to be an important part of care. As I thought about these models in the beginning, I thought that telemedicine would be most advantageous for patients in groups B and D, those who face those great social barriers. But it's also possible that the same things that move patients into that category will also prevent them from wanting or being able to access those models.
Yeah. Thank you. Catherine also had a question, and regarding global billing and practice modification for COVID, did reimbursement stay the same? Were any funds carved out for the non-physician providers?
So that's a great question. I'll start with the payment. There were lots of changes in reimbursement for telemedicine during the COVID-19 pandemic. Those did not directly affect us in Michigan for prenatal care, again, because of this bundled or global payment. Bundle refers to everything being covered in one payment versus global, which really refers to the provider component. Most of the Michigan payers function in that global payment structure. Throughout that time, we were having conversations with payers to make sure that our visit number would be equivalent to the total number of prenatal visits and wouldn't be broken down with a difference between in-person and virtual. And we were really fortunate that our payers were quite sympathetic. And so that did not change in our prenatal care sense. One of the big negotiations that we had in payment was who would cover the home devices. As the providers move, or the health systems move to virtual care, the model historically had been that they themselves would cover the devices. So places like the University of Utah, UPMC out of Pittsburgh, those health systems, some of which are combined payer providers, have just purchased those devices on their own. But in Michigan, that model really didn't work for us. We've been fortunate that many of our payers have been willing to provide those devices. Did I cover all the components of that question? I think I might have missed something.
No, I think that's good. And then we can ask more questions. And Anne had a question about if they've researched how this applies to postnatal care as well.
That's a great question. The postpartum period is certainly an important time for patients. I will say that my focus has been antenatally, but also, applying those lessons to after delivery. We did convert many of our postpartum visits that didn't require in-person services to virtual during the pandemic. And we'd actually been trying a couple of different visit models, things like doing a depression screen or a mood check. That can be done quite easily over the phone or through a video visit. And especially for new moms who have a baby at home and don't want to go out in the cold or in the time of a pandemic want to minimize exposure, these are really great models that improve the flexibility of care. There are great studies on blood pressure monitoring remotely in that period, and I'm happy to send some of those references if that would be of interest. And I think that we're going to see an increasing use of the virtual visit for those postpartum check-ins that don't require exams or labs in the future.
Okay. Thank you. And Timothy has a question in the chat, and he asked, as you roll out your scientifically measured implementations, what are you doing to monitor and prevent reversion to old habits by providers and professional societies, which resisted these changes for years and leapt on board with COVID? How sustainable do you see these changes being, and what is in place to keep them so?
Yeah. Thanks, Dr. Johnson. That's a huge question. I'd say we're working on that through a couple of approaches. The first I'll say is through my K Award, which, just for those of the audience who don't know, that's an NIH-funded training grant, which is a great opportunity for folks who are interested in pursuing a research career after they finish their doctoral training. And that will really be looking at people who do and do not adhere to these care recommended guidelines and going into why. My sense is that places where people are deviating are a reflection of where we're not meeting their needs. And so figuring out what those needs are and then addressing them right from the beginning so that medical care is being delivered by maternity providers and some of that supportive care is being delivered by other healthcare workers will help to address that. I'm also fortunate to work with a great group of implementation scientists, including Michelle Moniz. And that group rigorously studies implementation and uses scientific frameworks to think about those kinds of questions. And so that is all baked into the work that we are applying for grant funding for now. I think the final piece is the partnership with Acog. Back in 1989, a prenatal visit schedule, very similar to what we've proposed during COVID-19, was released from the NIH after a big consensus panel. But the problem was that Acog did not endorse it. And maternity care providers really need that professional society endorsement before switching into new realms. So this time, we're not only creating new guidelines, but actually for the next 2 years, I'm going to go to all of the major maternity provider organizations, patient organizations, payers, and talk to all of these different groups, figure out where these guidelines may meet resistance, and then help to release a new set in 2 years that address all of those issues. So we hope by sort of staying on top of it, we'll actually be able to sustain change.
Yeah, that's really great. Thank you so much. I think that like we're on time it's going to be our last question. But thank you so much. We're so grateful to have you as our partner at CHEPS and to have you present. This was like a wonderful, really well thought out presentation, very easy to understand, no jargon at all. Really well done. So.
Well, thank you so much. And I'm happy to stay on for another 5 or 10 minutes if people have burning questions. If that's okay with you guys, I'm happy to do so.
Amy, up to you.
Yeah, let's go ahead. We'll leave the chat open and we'll leave the room open, and I'll stay on with Alex and give people a few more minutes. If they've got one-on-one questions, they can, I think we can just unmute the group and then we'll kind of wrap it down as